It's my pleasure to invite two eminent speakers to discuss the next topic, which is a rather very hot topic again, with the use of non-steroidal anti-inflammatory drug in patients with CKD. The first one who will defend this subject is Dr. Tarek Tantawi. I think we all know.
We change Professor Magdi. I will start.
Okay,
Professor Tarek will come
we'll start by Professor Amir. Dr. Amir طبعا العقيلي is one of the eminent nephrologists from the AZI. He's a dear brother and friend. He will state the cons against the use of non-steroid.
Bismillah ar-Rahman ar-Rahim, Mr. Chairman, dear colleague, it is a great pleasure to be with you today. Actually, the title of my presentation, can non-steroidal anti-inflammatory drug be used safely in CKD patient? I think it is an old question and difficult questions to answer. I will try to go through the hazardous effect of non-steroidal anti-inflammatory drug in the kidney, and my friend Professor Tarek will go through the solution and the choice of other different medication which can be used safely instead of non-steroidal anti-inflammatory drug. First of all, non-steroidal anti-inflammatory drug usually work by inhibiting cyclooxygenase and therefore alter prostaglandin synthesis in many tissue with range of side effect beyond their intended one. Non-steroidal anti-inflammatory drug have a number of well-known adverse effects regarding the kidney, gastrointestinal, even the cardiovascular system with a strong connection with the kidney. Also, adverse effect profile vary by the drug and but depending on relative selectivity of COX-1 and COX-2 IDO enzyme, with more COX-2 selective inhibitor having lower risk of GI bleeding but higher risk of cardiovascular disorders without marked effect on regarding the kidney. Non-steroidal anti-inflammatory drugs also are a common cause of drug-related emergency hospital admission, drug-related death from GI bleeding, acute kidney injury, serious cardiovascular events. Regarding non-steroidal anti-inflammatory drug, the international consensus guideline recommend trying to avoid non-steroidal anti-inflammatory drug in people with estimated GFR 30 ml per minute and to avoid prolonged use on patients with estimated GFR from 30 to 59 ml per minute. A systemic review of non-steroidal anti-inflammatory drug use in people with CKD and 7 cross-sectional study found that 8 to 29% were currently taking non-steroidal anti-inflammatory drug, and another randomized control trial examining non-steroidal anti-inflammatory drug effectiveness routinely exclude people with chronic kidney disease and often don't evaluate renal outcome on this group of patients. So, there is two forms for cyclooxygenase enzyme, either COX-1 and COX-2. COX-1 is expressed constitutively in many tissue and maintain baseline physiological function, including maintenance of kidney function, regulation of platelet aggregation, protection of gastric mucosa. COX-2 expressed by or modified by growth factor, cytokines, and other external signal, upregulated in response to inflammation. COX-2 is also constitutively expressed in the kidney, and COX-2 is largely responsible for increased prostaglandin production under circumstances requiring augmentation of the renal blood flow, including in case of reduced effective circulating volume and reduction of the estimated GFR. These are the distributions of COX-1 and COX-2 in the kidney, and as we see, text in green showing the distribution of COX-1, blue COX-2, and black location of overlapping COX-1 and COX-2, and as we see, there is great distribution of COX-1 and COX-2 in the kidney and the release of prostaglandin responsible for their effect. And these are diagram illustrating the pathophysiology of non-steroidal anti-inflammatory drug-induced kidney injury through inhibition of cyclooxygenase, leading to reduction in the total renal perfusion, sodium and water retention, resulting in renal vasoconstriction, which leads to chronic kidney disease and sometimes acute kidney injury. These are the distribution of the prostaglandin in the kidney, prostaglandin E2 and I2, sodium and water retention, the main effect by the proximal convoluted tubules, and also sodium retention and potassium wasting by the distal convoluted tubule through the effect of aldosterone. I'll skip some of my slides because of the shortage of time. And these are the hazardous effect of non-steroidal, as we said, sodium retention, hyperkalemia, and AKI. What about the adverse effect of non-steroidal anti-inflammatory drug on the kidney? As we see, most of the kidney or a lot of hazardous effect usually induced by non-steroidal, including acute kidney injury, hyperkalemia, hyponatremia, hypervolemia, exacerbation of hypertension, acute interstitial nephritis, nephrotic syndrome, acute or chronic papillary necrosis, and progression of CKD. And these are the precipitating factors for different problems, including acute kidney injury, maybe through circulating volume depletions, high cumulative dose exposures, concurrent medication, including calcineurin inhibitor and RAS inhibitors, hyperkalemia, older patient, type 4 renal tubular acidosis, exposure to radio contrast media, and hyponatremia, hypervolemia, worsened hypertension, and progression of CKD. Regarding this hazardous effect, I will not go through the details because of the shortage of time, but non-steroidal anti-inflammatory drug and AKI, and I think I said before, it is multiple contributing factors leading to acute kidney injury in these groups of patients, including different medication, old age, multiple comorbid condition like diabetes, hypertension, and different medication used. The CKD population is a complex patient cohort with significant comorbid disease burden, and these comorbid condition, their complication and their management frequently leads to significant AKI risk factors. Hypervolemia. A recent meta-analysis of randomized placebo-controlled trial found 70% increased risk for congestive heart failure and edema with selective COX-2 inhibitor use versus placebo, even when excluding high-risk agents such as rifacoxib. What about hyperkalemia? A nested case control study of La France and Miller quantified the risk for the development of hyperkalemia with potassium level more than 6, imposed by non-steroidal anti-inflammatory drug in patient population of veteran, no increased risk with either single or multiple non-steroidal anti-inflammatory drug, but the other cofactors which may lead to hyperkalemia, including prior episodes of hyperkalemia, hospitalization, diabetes, and acute kidney injury with different medication, hypertension. There is also a meta-analysis including 1,200 patients, non-steroidal increased blood pressure primary in patients with underlying hypertension, patients with advanced age, diabetes, and CKD also appear to be increased risk. What about acute interstitial nephritis? Acute interstitial nephritis may occur in part due to shunting of arachidonic acid into lipooxygenase. And there is also some pattern of nephrotic syndrome, including membranous nephritis or minimal change in association with non-steroidal anti-inflammatory drug. Regarding the progression of CKD, also there is some issue saying that there is progression of CKD in a group of patients, especially old patients with multiple comorbid condition. Due to shortage of time, I'll skip some slides. And finally, this is a summary for potential nephrotoxicity. And as we see, stage 1 and 2, you can use non-steroidal anti-inflammatory drug to some extent safely. Regarding stage 4, almost moderately increased risk compared to the general population. Stage 5, try to avoid. Most of the medication, we should reduce the dose, shorten the time to avoid the nephrotoxicity. Finally, my conclusion. Thank you very much. I'll skip my conclusion.
Please tell us your conclusion. What is your conclusion?
My conclusion is non-steroidal anti-inflammatory drug got some sort of nephrotoxicity implicated in development of acute kidney injury, progression of chronic kidney disease, acute interstitial nephritis. Try to avoid the use of non-steroidal anti-inflammatory drug as much as you can. And if you are going to use it, try to use it for short period of time, a small dose to avoid the nephrotoxicity. I think Professor Tariq will find to try to find some solution for this problem.
Thank you very much, Professor Amir.